Hello, I'm Dr. Brian Haas, National Medical Director for Ascend Hospice and the founder of Hospice Intelligence. If you're a hospice nurse, administrator, or clinical director, I know your day. It's a demanding mix of essential patient care and the seemingly endless documentation required by Medicare. I've witnessed your struggle firsthand. The worry that your teams might be missing crucial local coverage determination, or LCD criteria. I've been there with my own clinical teams, watching them drown in the same paperwork you face every day, jeopardizing compliance as well as reimbursement. That's why I created Hospice Intelligence. This channel is dedicated to navigating Medicare's complexity together. My goal is simple: to show you and your teams how to effortlessly capture 2 to 3 additional LCD criteria without sacrificing more of your precious time. Your team's focus belongs with your patients, not buried in charts. Let's shift the balance and make compliance an asset, not a burden. First, let's establish why this topic is so critical. So in hospice care, your clinical documentation serves 3 essential purposes. First, it's the official record of the care you provide, clearly. Second, it's your primary communication tool across the interdisciplinary team. And thirdly, and this is where many agencies struggle, it's the evidence that Medicare reviewers use to determine whether your patients qualify for the hospice benefit. Now, let's pause and think about that for a moment. A Medicare reviewer wasn't at the bedside with you. They didn't see your patient's labored breathing, their inability to recognize their own family members, or their complete dependence for every activity of daily living. Crucially, the reviewer is not often a clinician. They're a claims specialist or an administrative personnel. The only window that they have into that clinical reality is your documentation. Your narrative must paint a complete and vivid picture for this non-clinical person, ensuring the clinical severity and the justification for hospice are undeniable. This is why narrative writing is so much more than just filling out the note. Your documentation must paint a complete picture that demonstrates terminal illness, progressive decline, and limited life expectancy, all while reflecting the individual patient's unique journey. And here's the critical part. It must do this while incorporating the specific criteria outlined in Medicare's local coverage determinations. These LCDs provide the framework that reviewers use to assess hospice appropriateness. If your documentation doesn't clearly connect your clinical findings to LCD criteria, even patients who legitimately qualify for hospice may face denial or your agency facing recoupment. The stakes are high. According to recent industry data, documentation deficiencies are among the top reasons for hospice claim denials and survey findings. But here's the good news. Most documentation problems are completely preventable. Once you understand what to avoid and what to include, the rest takes care of itself. So let's talk about some of the mistakes I see most frequently in hospice documentation. If you recognize yourself in any of these, don't worry, you're not alone, and we'll discuss solutions shortly. Pitfall number 1, the template trap. Now, many electronic health records, they offer templates and drop-down menus designed to help you speed up documentation, supposedly. And yes, they can improve efficiency, but over-reliance on these tools creates a serious problem. When you're selecting from pre-populated options, your documentation starts to sound, well, generic. Every patient's note reads similarly. You see phrases like patient is declining or condition worsening appearing over and over without any specific supporting details. So here's what happens. A Medicare reviewer reads 10 charts from your agency, and they all sound pretty similar. This raises immediate red flags. It suggests that documentation doesn't reflect individualized assessment, which is a cornerstone of quality hospice care. More importantly, this vague, templated statements don't satisfy the LCD requirements. The LCDs require specific, measurable indicators of disease progression. Saying patient is declining doesn't cut it. You need to document exactly how they're declining with concrete clinical details. Pitfall number 2, missing the LCD connection. This is perhaps the most common mistake, and it's particularly frustrating because the clinical information is often present in the note. It's just not connected to the compliance framework. So let me give you an example. You document that your patient has lost 12 pounds over the past 2 months. That is certainly an important clinical observation, and you've recorded it. But you don't explicitly identify this as progressive weight loss under the debility LCD or as part of the decline related to their primary diagnosis. So you've missed the opportunity to strengthen your compliance documentation. For even greater clarity and compliance, you should also calculate and state the weight loss as a percentage of the patient's body weight. So let's give this as an example. For instance, if the patient weighed 150 pounds 2 months ago, a 12-pound weight loss represents 8% weight loss. See how we do that? 12 pounds divided by 150 equals 0.08. Multiply that by 100, you get the math. The percentage is often a key criterion cited by Medicare local coverage determinations for demonstrating decline, such as a significant or unintentional weight loss of 10% in the last 6 months or 5% in the last 3 months. By including this percentage, you directly align your narrative with the clinical evidence thresholds auditors are looking for. Or consider this, your note that the patient is experiencing increasing shortness of breath, requiring more oxygen, and having difficulty speaking in full sentences. Again, excellent clinical observations, but if you don't connect these findings to end-stage cardiac or pulmonary disease indicators in the LCD, a reviewer might not make that connection either. This disconnect happens because clinicians are focused, appropriately so, on immediate care needs. You're thinking about symptom management, patient comfort, and family support. But documentation requires an additional cognitive step on your part, mapping your clinical findings to the LCD framework. All right, pitfall number 3, snapshot documentation. Hospice is fundamentally about managing terminal decline over time. Yet many visit notes read like isolated snapshots rather than chapters in an ongoing story. Each note should reference previous assessments and clearly demonstrate change. When did the patient transition from walking with assistance to being bedbound? How has their oral intake decreased over the past month? When did the confusion progress from occasional to persistent? Without this temporal perspective, it becomes difficult to demonstrate the progressive nature of terminal illness. A single snapshot might show a patient who appears stable, but the trajectory over time tells the true story of decline. Medicare reviews place a high premium on evidence of progression when evaluating a patient's continued eligibility for hospice care. Without clear, consistent, and comprehensive documentation demonstrating a decline in health trajectory, your organization is exposed to significant compliance vulnerability, even if the patient undeniably meets the clinical criteria for ongoing hospice certification. The critical areas to document decline and disease progression can be included in the following 6 domains. So I'm going to list out the 6 domains to start with, and then we're going to go back through each individual one. So the first one is functional changes. The second one is cognitive declines. The third one is disease progression. The fourth one is worsening symptoms. The fifth one is nutritional declines. And lastly, the sixth one is your LCD criteria again. So now let's break these down individually. So going back to our first one, which is functional changes, activities of daily living or ADLs. Now focus documenting a progressive loss of independence and increased reliance on your caregivers. So that's where your focus is going to be. Now your evidence is going to show decreased ability to perform self-care tasks, bathing, dressing, toileting, feeding, ambulating, transferring, etc. Lowering scores on validated functional scales like the Karnofsky Performance Status Scale or the Palliative Performance Scale. Those are KPS or PPS. New need for assistive devices or increased assistance level, moving from minimal assistance to extensive or total assistance. Number 2 is our cognitive declines. Now we want to focus on documenting a measurable deterioration in mental status, orientation, decision-making capacity. Maybe they're showing increasing confusion, disorientation to person, place, or time, new or worsening short-term memory loss, difficulty with communication, expressing needs or understanding instructions, changes in behavior such as increased agitation, withdrawal, or wandering. Now, some people think that this can only be shown in those patients that have cognitive declines like dementia, but that's not the case. This can occur in Liver disease as well, showing worsening hepatic encephalopathy over a period of time. The same thing with renal disease, showing ongoing issues with uremia. And finally, it can even be shown in the setting of cardiac or pulmonary disease from an aspect of CO2 retention causing a CO2 narcosis, or even from a cardiac perspective due to poor cardiac perfusion and decreased cerebral perfusion. All right, now let's move on to disease progression. So primary diagnosis or comorbid conditions. So these are where we want to focus on our objective signs that the primary terminal illness or significant comorbid conditions are advancing. So in regards to cancer, documentation of new metastasis, tumor growth, or failure of recent treatment efforts. For heart failure or COPD, we could use increasing frequency or severity of dyspnea, new or worsening edema, more frequent hospitalizations or ER visits for exacerbations. Dementia, we could use our FAST score. General findings like lab findings, if we did those, recurrent infections, etc. Then we have, of course, worsening symptoms. So documenting the escalating severity and intractability of physical and psychological symptoms. So uncontrolled or newly controlled pain, increasing nausea, vomiting, intractable constipation, worsening anxiety, depression, spiritual distress that requires intervention, frequent and severe episodes of agitation or delirium. All right, number 5, nutritional declines. We want to focus now on documenting measurable evidence of weight loss and declining nutritional intake. So involuntary or significant weight loss, and we could use those LCD criteria of 10% in the last 6 months or 5% in the last 3 months that cannot be attributed to a temporary illness, progressive decrease in appetite and oral intake, documented signs of cachexia or muscle wasting, that's also known as sarcopenia, refusal or inability to take nourishment, leading to dehydration or malnutrition. It's also very important that we can see how the change in their appetite is occurring. So maybe they were eating, breakfast and they ate cereal or oatmeal along with a piece of toast. And then 2 months later, they're now only eating a couple of bites of a small bowl of cereal and they're not eating the toast any longer. Now, number 6 is our local coverage determination criteria. And again, documenting the specific disease-related clinical findings often explicitly listed for those disease-specific criteria. Robust documentation is not merely reporting facts. It is constructing a narrative of inevitable decline that justifies the continued provision of the Medicare hospice benefit. Every certification and recertification period must be supported by progress notes that collectively demonstrate this clear, negative trajectory. Now, a key caveat here. It is important to note that in each certification period, you may not have data to support decline in each of the 6 noted domains. However, the more you focus your attention on documenting in these 6 domains, the more likely you are to identify and capture relevant changes. If you document a decline primarily in the functional and cognitive domains for one certification period, and in the next certification period you capture a change in multiple LCD criteria and significant weight loss, you're still effectively demonstrating the required negative trajectory of decline across the patient's journey. Documentation should demonstrate a cumulative pattern of decline, not necessarily a concurrent, i.e. decline in all domains at every single visit. This cumulative tracking of decline from one certification note to the next is what we are working on at Hospice Intelligence. Now let's get to pitfall number 4, insufficient specificity. So basically, general statements are the enemy of strong documentation. So let me contrast 2 examples for you. All right, so here's example number 1. Patient is bedbound and has a poor appetite. Okay. Example 2. Patient is now completely bedbound, unable to reposition independently, requiring a 2-person assist for all transfers. Patient has not attempted to get out of bed for the past week. Regarding nutrition, patient consumed only 3 bites of pudding and 4 sips of water in the past 24 hours, refusing all other food offered. This represents significant decline from 1 month ago when the patient was transferring to the chair with 1-person assist and eaten approximately 50% of meals. So which one of those 2 paints a clearer clinical picture? I like the second one. Which one documents the LCD criteria like functional decline and decreased oral intake? Which one would be more compelling to a Medicare reviewer? The second example, of course, it provides specific and observable details and includes comparative information showing progression. This is the level of specificity your documentation needs. It shows declines in 2 out of the 6 domains that we discussed earlier. All right, let's move on to pitfall number 5, siloed documentation. So comprehensive timed intervals, CTIs, and nursing notes shouldn't exist in isolation. They must reflect input from your entire interdisciplinary team and synthesize multiple perspectives into a cohesive narrative. If the social worker has documented increasing caregiver burden, the chaplain has noted spiritual distress related to end-of-life transition, and the aide has observed declining hygiene tolerance, these observations should inform and appear in your nursing documentation. Hospice is interdisciplinary care. Your documentation should reflect that reality. When notes ignore valuable inputs from other team members, you miss opportunities to strengthen the overall clinical picture and demonstrate comprehensive assessment. All right, so now that we've identified what not to do, let's talk about best practices. These strategies will help you craft narratives that are both clinically rich and compliance focused. So best practice number 1, assess first, then map to the LCD criteria. Your priority during any patient visit must always be clinical assessment and care delivery. You're a clinician first, not a documentation specialist. However, when you sit down to write your note, taking the intentional step of mapping your clinical findings to relevant LCD criteria, that's necessary. If you assessed neurologic status and noted increased confusion, decreased responsiveness, or difficulty with speech, recognize these as indicators under dementia, debility, or disease-specific LCDs. Document them explicitly as such. That doesn't mean forcing clinical findings into inappropriate categories or documenting things you didn't observe. It means recognizing which legitimate clinical observations support hospice appropriateness and ensuring those connections are crystal clear in your documentation. Best practice number 2, use comparative language consistently. Every single visit note should include comparative statements. Now, make this as a non-negotiable part of your documentation practice. Use phrases like compared to last visit, deterioration noted since admission, progression from previous assessment, or decline over the past month. Then provide specific details about what has changed. This creates a documented trajectory that reviewers can follow throughout the certification period. It transforms your individual notes into a coherent narrative of terminal decline. Best practice number 3, replace general statements with specific details. Train yourself to automatically add specific details to clinical observations. Instead of documenting poor appetite, write, the patient consumed only 2 bites of scrambled eggs and 3 sips of juice this morning, leaving 95% of breakfast untouched. Wife reports this represents typical intake over the past week. Instead of increased weakness, document the patient's arms tremble when attempting to lift cup to mouth. Requires total assistance for all transfers. Unable to sit unsupported for more than 2 minutes without listing to the side. These specific details accomplish 2 things. They satisfy Medicare documentation requirements, and they genuinely reflect clinical reality more accurately. It's not about writing more. It's about writing with precision. Best practice number 4, explicitly connect symptoms to disease progression. Never assume that reviewers will make clinical connections on their own. They probably can't. They're non-clinical reviewers. Your job is to connect the dots explicitly in your documentation. If your patient with end-stage COPD is experiencing increased dyspnea, explain how this relates to disease progression. Patient's dyspnea at rest has worsened significantly over the past 2 weeks, now requiring continuous oxygen at 4 liters with saturations ranging from 88 to 91%. Patient becomes severely short of breath with any exertion, including speaking more than a few words. These findings are consistent with end-stage COPD progression and indicate advancing respiratory failure. Now you've done 3 things. You've documented specific clinical findings, connected them to the underlying terminal diagnosis, and explicitly identified them as indicators of disease progression. That's LCD integrated narrative writing. All right, let's bring this home. Best practice number 5, document the functional impact. LCD criteria heavily emphasize functional decline and dependence in activities of daily living. Every assessment should address how the patient's condition affects their ability to care for themselves. Don't just document that your patient has weakness or pain. Document that the weakness means that they can no longer walk to the bathroom independently, that the pain prevents them from dressing themselves, that the confusion means they can't safely be left alone. The relationship between disease progression and functional loss must be explicit and detailed in your documentation. So how do you actually implement these best practices consistently, especially when you're managing a full caseload with back-to-back visits? So let's do some practical strategies. Strategy number 1, you could create a personal documentation checklist. Develop a mental or written checklist of LCD criteria relevant to your most common patient populations. Before you finalize any note, run through this checklist. Have you addressed functional status, weight changes, oral intake, disease-specific progression indicators, comparative statement showing decline? This takes less than a minute or 2, but dramatically improves documentation and completeness. Strategy number 2, use the tell the story approach. Think of your documentation as telling a story to someone who wasn't there. What would they need to know to understand this patient's clinical situation? What details would paint the clearest picture? This storytelling mindset naturally leads to more specific, complete documentation. Strategy number 3, and what I think is personally the best, is to leverage real-time documentation support, like hospice intelligence. Here's the reality. Even with the best training and intentions, consistently producing LCD-compliant narrative documentation is challenging. You're juggling multiple patients, complex care situations, time pressures, and the cognitive load of simultaneously assessing, treating, and documenting. This is where technology can provide crucial support. Real-time documentation auditing, tools like Hospice Intelligence, can analyze your narrative as you write it, flagging gaps in LCD criteria coverage and suggesting areas where additional detail would strengthen your note. Think of it as having a compliance expert looking over your shoulder, but without the pressure. The system identifies opportunities to enhance your documentation while the visit is still fresh in your mind, when adding those details is easy rather than requiring chart review weeks later. This isn't about replacing your clinical judgment. It's about ensuring that the excellent care you're providing is accurately reflected in documentation that meets Medicare standards. It helps you recognize when you've documented clinical findings that support LCD criteria but haven't made those connections explicit. Strong narrative documentation that integrates LCD criteria isn't just about compliance, though that's certainly important. It's about telling the complete, accurate story of your patient's journeys and the skilled, compassionate care your team provides every single day. When documentation accurately reflects clinical reality and meets Medicare standards, everyone benefits. Patients receive appropriate care without interruption, clinicians feel confident in their work and protected from compliance concerns, and agencies maintain financial stability, which allows them to continue serving their communities. The documentation practices we've discussed today, avoiding common pitfalls, using comparative language, providing specific details, connecting findings to LCD criteria, and documenting functional impact, these are all skills you can develop and strengthen with practice. Start by focusing on just 1 or 2 best practices. Maybe this week you commit to including comparative statements in every note. Next week you work on increasing specificity. Over time, these practices become second nature and your documentation quality improves dramatically. Remember, you became a hospice clinician because you're passionate about providing comfort and dignity to patients at the end of life. Your documentation should reflect the quality of care you deliver. It should honor your patients' stories and showcase your clinical expertise. Look, Medicare isn't getting any easier on us, but you don't have to face this alone. I created Hospice Intelligence because I witnessed firsthand how documentation burden was stealing precious time from patient care. If what we covered today resonated with you, if you're tired of wondering whether you've documented enough, then it's time to talk to your leadership about the tool I built specifically for this problem. Share this video with your fellow nurses who are struggling with the same documentation burden. And if you're ready to stop playing Medicare's guessing game, have your clinical director or administrator reach out to us. Because at the end of the day, we all got into hospice for the same reason: to care for families in their most vulnerable moments. Let's make sure documentation supports that mission instead of stealing from it. Subscribe for more strategies that put patient care first. Until next time, keep being the compassionate voice your patients need.